afternoon, everybody. What I'll be talking is innovative solutions in managing vitreoretinal surgery in cases of traumatic in NRADIA with retinal detachment. Silicone oil in aphakic patient with traumatic NRADIA is a challenge, as silicone oil in AC can cause corneal endothelial decompensation and what we call as in silicone oil keratopathy and secondary glaucoma. In aphakic patient, inferior iridectomy with intact iris diaphragm allows aqueous to enter the AC and prevent silicone oil touching the cornea and pupillary block glaucoma. So silicone oil injection in aphakic patients with aniridia is relative contraindication. The aim of the study is to evaluate the efficacy and safety of silicone oil barrier sutures in maintaining silicone oil bubble behind the mesh in aphakic patients with traumatic aniridia with retinal detachment. It's a retrospective study of 5 eyes between 2013 to 2016. First vitrectomy with base dissection was done. Central 5mm zone was left. Grid of 10-0 proline sutures were created horizontally and vertically. We'll see how. Please put on the video, please. Video. You can see there is a traumatic aniridia. We have gone and done a pars plana base dissection. We are doing an internal drainage by creating an internal retinotomy. A 5.5mm zone is created, and then 10-0 Marceline suture on STC6 needle is passed 1mm behind the limbus and taken out from the opposite side 1mm behind the limbus. This needle is then reversed back, and again a grid is created. Like this, we create 3 sutures superiorly, 2 inferiorly, and we make 2 sutures, grid of 2 sutures on each side. So we create an proline mesh and we tie this suture on the sclera. What you can see, we are creating a vertical grid. And then it is sutured on the sclera. If we see on retroillumination, you can see 3 sutures here, 2 sutures here, and 2 sutures on the side. A fluid air exchange is done and silicone oil is injected. Peripheral laser is done, and then we push the silicone oil behind the proline mesh with a viscoelastic. These are our 5 patients. In all 5 patients, in 4 patients, silicone oil remained behind the mesh. In one of the patients, migration of the silicone oil happened after 6 weeks of the surgery. So 80% of the patients, the silicone oil remained behind the proline mesh, and 20% patient it progressed, it migrated into the ATA chamber. Mean follow-up time was 8 plus minus 2.8 months. UBM study showed, and slit lamp biomicroscopy showed silicone oil meniscus behind the silicone oil barrier sutures in 4 patients, of that is 80% of cases. One eye showed migration of silicone oil in AC after 6 weeks. That is because of anterior PVR. These are some of the cases. You can see aniridia with aphakia, with corneal tear repair, with detachment. These are post-operative patients. You can see a silicone oil mesh, proline mesh, and silicone oil. If you see the UVM study, the silicone oil, you can see the meniscus, silicone oil meniscus behind the sutures. So these sutures were preventing silicone oil migration into the anterior chamber. There is another patient of trauma, one-eyed patient. You can see silicone oil barrier sutures, and in this patient, silicone oil migrated into the AC because of the anterior PVR, and this is another patient. You can see sutures here. Coming to discussion, in aphakic patients, inferior iridectomy with intact iris diaphragm allows aqueous to enter the AC and prevent silicone oil touching the cornea and pupillary block. So silicone oil injection in aphakic patient is in contraindication. There are 2 studies. One is Gentile and Elliott, described 3 cases, and Usul K has described 10 cases, and we have a series of 5 patients in our study. Silicone oil retention sutures prevent silicone oil from entering the AC. Silicone oil aqueous interface surface tension is as high as 50 ERG per centimeter square. This is because of interfacial tension, that is because of van der Waals and polar bonding forces helps to maintain spheroidal shape. These forces prevent suture breaking the surface of silicone oil tubules. It also overcomes the low buoyancy of forces of silicone oil. In our series of 5 patients, silicone oil retention sutures were able to prevent migration of silicone oil in the anterior chamber. Late migration in patients occurred due to anterior PVR and hypotony. Success of this technique would not be expected in eyes with overfill of silicone oil, inadequate aqueous production. 3 patients underwent silicone oil removal with removal of silicone oil retention sutures after 3 to 4 months. So to conclude, silicone oil barrier sutures were able to prevent silicone oil in AC, thus preventing silicone oil keratopathy and secondary glaucoma. It is an innovative technique to salvage eye which were considered blind and unoperable. Thank you.
But after this, did you see any? What are the long-term follow-up?
So we followed for the mean follow-up was between 8 plus minus 2.8 months. Okay. 3 patients we removed the silicone oil, and along with the silicone oil, we removed the silicone oil retention sutures.
Right. But so anybody has developed corneal problem after the keratopathy?
So one eye there was a migration of silicone oil into the AC because of the anterior PVR. But for 6 weeks it remained behind the proline mesh. So in none of the patients we had secondary glaucoma or silicone oil keratopathy.
Okay. Thank you. Thank you.
Anything you would like to say comparison between using the IOL as a platform to prevent the silicone oil migration and this suture difference?
Sir, if we don't have a posterior capsule in this patient, so the lenses what we can use is glued scleral fixated IOL. But if you use glued scleral fixated IOL with silicone oil, the problem is with the sclerotomy, these oil tends to leak and we are not able to close the sclerotomy. There are 2 platforms available. There are PMA platforms, 5.5 millimeter diaphragms which are available. And European Society, some people have used it, but there was a lot of inflammation and patient landed up with phthisis bulbi with hypotony. So that is not in use. So this is one of the simple methods without opening the anterior chamber, just creating a proline mesh, keeping the silicone oil behind. We are able to prevent silicone oil keratopathy and secondary glaucoma. And plus we are able to tackle those patients which we thought were unoperable. See, if I can't use silicone oil and if I have a difficult RD, I won't go in for surgery. Yeah. So we were able to save these kind of difficult patients.
Anything you feel like a number of sutures to create a mesh, like you said the other study is triangular and this is
the basic thing is ki 5.5 millimeter central zones should be there, and you have to put 2 on each side, 2 to 3 sutures on each side.
So how much central area can be left?
5.5.
5.5 is
that is the minimum what you can leave. You can leave 4.5 also, but yeah, minimum should be 5.5.
And what about the suture knots? They were buried.
Sutures not they were on the sclera. They were not buried.
Okay, but so there was no erosion through conjunctiva and no
erosion. They were covered with conjunctiva. And with this 3-4 months, we were able to remove 10-0 proline sutures.
Good. Thank you. Ekta Rishi, are you ready?